Yes. So only a few years ago, we were not even able to achieve a clinical complete remission in CLL, and now we found ourselves to speak about the possibility to achieve MRD negativity, minimal residual disease negativity in our patients. And first of all, we have to define what we mean for MRD negativity, and this is reported in the International Workshop on CLL Guidelines. And we mean for negativity not the absence, the absolute absence of leukemic cells, but also only the fact that we can detect less than one cell out of 10,000 leukocytes, which means 10 to the minus 4. Please keep in mind this number because it will come back again in the next slides. So this is a technical limit. Nowadays, we are not reliably, we are not capable of reliably detecting any cell below that threshold, and this is due to the fact that we have these two methodology, the four-color flow cytometry and the PCR, that do not allow to reach a lower level, a lower threshold for MRD negativity. So just to make the field clear, these are the two methodologies. In many studies in the past, they were claiming to study MRD negativity, but they were studying it with a consensus PCR that is able to reach only 10 to the minus 2 or 10 to the minus 3 cells. So this should not be used anymore, and only the quantitative PCR, so RQ-PCR, as you would call it, that is able to reach 10 to the minus 4 threshold. For the phenotype, for the flow cytometry technique, again, many studies have been done with two-color staining, the classic CD19, CD5 staining, and those are not, again, reliable because they cannot reach a threshold lower than 10 to the minus 2. So nowadays, at least a four-color technique should be used to reach 10 to the minus 4 technique. And I just show you quickly that there is an internationally recognized protocol, or four-color protocol, that was validated by, through the ERIC, the European Research Initiative on CLL, together with many centers also in the United States. We improved the system, and we recently published it with a six-color technique that reduces the amount of material that you need, the amount of time, and also the cost. And now we are exploring the possibility to further improve the system with an 8-color technique that would really reduce time and money used for the analysis. In the future, as I said, it is possible that we will be improving our techniques, and one is for sure the next generation sequencing that is claiming to reach a threshold of 10 to the minus 5, if not 10 to the minus 6, so one cell out of 1 million leukocytes. And indeed, so far, preliminary data show that there is a very nice correlation with the PCR as well as the flow cytometry, the four-color flow cytometry technique, and this will be universally applicable, and but it remains still to be validated in large clinical trials. But still, I think that in a couple of years, this will be probably will take over all the other techniques. Second thing that I want to share with you is where we have to detect, analyze the presence of minimal residual disease. Again, in the guidelines, it has been reported that the blood, peripheral blood, is a very good detection of MRD in the blood is predictive of survival, and is as good as bone marrow, except the cases where one uses antibodies like alemtuzumab and rituximab because they, of course, clean lymphocytes much more easily in the peripheral blood as compared to the bone marrow. This is a work that we published a few years ago together with Andy Rostrom, showing indeed a very nice correlation between the detection of MRD in peripheral blood versus bone marrow. Still, the bone marrow analysis appears to be more specific, and indeed, when the technique was validated within clinical trials, this is again work by the English group, show that indeed 25% of the samples that were negative, so they were below 10 to the minus 4 in the peripheral blood, still they were at a higher level in the bone marrow. So though the peripheral blood, of course, is much more easier and convenient for the patient, the bone marrow maybe remains the gold standard in the clinical trials, and the general consensus would be to assess MRD 3 months after the completion of the therapy in the bone marrow. But after showing that we are able to detect minimal residual disease and where, is it meaningful to get to MRD in chronic lymphocytic leukemia? Yes, it is indeed, and that was shown already a few years ago by the use of only monotherapy like alemtuzumab, and indeed MRD negative patients have a better progression-free survival and also an overall survival. This has been also confirmed using immunochemotherapy. This is the MD Anderson work, again showing that MRD negative cases indeed have a better progression-free survival and overall survival. The most relevant work to confirm the relevance of MRD is, of course, the study done in the CLL trial, the FCR versus FC German trial, and they indeed show that, first of all, they define a different threshold of MRD, so less than 10 to the minus 4, so what is negative threshold, and then intermediate level between 10 to the minus 2, 10 to the minus 4, and then 10 to the, more than 10 to the minus 2. The first important thing is that, of course, you get more MRD negative cases using FCR, but still you do get cases that are negative for MRD or also using only FC. Second thing is that, again, there is a very nice correlation between the levels of MRD, 10 to the minus 4, intermediate levels, 10 to the minus 2, and you have a better progression-free and overall survival. And this is independent on how you get to the MRD negativity. So both FC and FCR cases who reach 10 to the minus 4 indeed have a better progression-free survival and overall survival. The other point is that the advantage of MRD negative status is even significant compared to the clinical response. So this is true, of course, among people who reach clinical complete response, so the one who have 10 to the minus 4 level have a better survival, but also among those who have a partial response. And these are the patients who usually do not recover completely platelet counts, neutrophil counts from the bone marrow, suggesting that in that particular case, in those particular cases, MRD is definitely much more precise in predicting the outcome. So here I want to show you where maybe the future is taking us, though it's still all preliminary data and still to be validated in clinical trials. This is the work done at the MD Anderson by Paolo Strati and presented a few months ago, where he showed that indeed if you consider patients who have been treated only with 3 cycles of FCR and not 6 cycles, some reached already MRD negative status after 3 months, some didn't. But then if you go and check for their progression and overall survival, then you would see that those who reached the MRD negative status after 3 cycles perform as good as those who reached after 6 months, after 6 cycles. And so suggesting that really MRD can be predictive of the outcome of the patient. This is, of course, still to be confirmed, so don't go out and treat your patient only with 3 cycles of FCR if they can bear 6. So what about the new treatments? So the so-called targeted treatments. And we show you this morning the data of CLL11 comparing chlorambucil versus chlorambucil plus rituximab and GA101 or GA101. And indeed, I show you that there is a higher frequency of complete remission, but also we have also for the first time in the elderly unfit population also MRD negativity. And MRD negativity, around 20% when detected in the bone marrow. This is better, of course, with GA101 as compared to rituximab, where it is really irrelevant. And again, the presence of MRD negativity is actually a predictor of outcome as among the people who do not reach MRD negativity. Similar data are obtained also in the complement one, so chlorambucil plus ofatumumab. I don't have the progression-free survival data, but you can see here that indeed you can get around 12% of cases that reach MRD negativity among those who are in clinical remission, complete remission, and again here they show that you can have also MRD negativity in the patient who reach only partial responses at clinical level. And we move even forward. These are data from ABT-199, so using a non-chemotherapy approach. And here, John Seymour studied also MRD status. One has to say that the data are still quite preliminary, and only out of 8 cases studied for MRD, only one was studied with high sensitivity techniques, so below, who can reach the threshold below 10 to the minus 4, and this one is the only real negative patient with negativity for minimal residual disease, but still it shows that though anecdotally monotherapy with non-chemotherapy agent can reach MRD status. But now we are facing the other new drugs, and ibrutinib and idelalisib and many others, TKI, and we all know that indeed we have a very nice decrease of lymphadenopathies, but still we have a very high rebound in lymphocyte count that can persist over 2 years even. So many people could think that, and some physicians I heard also this morning are attracted by the idea that probably we don't need to get to complete remission even, but we can keep our patients for years with the lymphocytosis. But we don't have to forget this paradigm that we learned from other leukemias and from other hematological fields, where indeed it is always better to get a deeper remission, so complete remission and even an MRD negative status if we want to really cure our patients. And also we don't have to forget that by keeping cells in our body circulating in the blood, we don't know really what's going to happen, and we know that nowadays we have cases that are relapsing after ibrutinib and idelalisib. They are becoming refractory to the treatment because of mutations that arise or develop or expand, depending how you see the thing. That's why I still think that even with these new drugs, we have to aim for complete remissions and even probably aim for MRD status. And this can be probably achieved by combination therapies. Here I show you both data with ibrutinib and idelalisib. You saw much more data this morning showing that indeed by combination with a simple anti-CD20, but even with chemotherapy, then you can get to complete remissions. You can increase the rate of complete remission, and very likely you can also increase the number of MRD negativity status. And indeed, this is the hope of for the design of this study of the UK consortium, where they will compare a first-line young fit patient, the use of SCR versus ibrutinib plus R, and the patients will be followed by MRD assessment every 3 months. And the interesting point is that the use of ibrutinib will be stopped based on the MRD negativity status. So this is really a very interesting study. Similarly, there are many other studies that are opening with other novel therapies aiming on eradicating somehow the disease, aiming for the MRD status. Here is again another British study where people treated with any kind of therapy who are in complete remission or partial remission, they can aim for MRD negativity by consolidation with GA101. And similarly, this German study, where also Italy is strongly implicated, where indeed the patient who reached a complete remission or a partial remission with MRD still positive can be consolidated with lenalidomide, and these are the patients indeed who do not reach 10 to the minus 4 level after the first line therapy. Having said that, and this is my last slide, the thing is that why do we need also MRD? Because probably we don't want to wait years, if not decades, to have new drugs. Now with the FCR, who has reached a plateau of 40% of patients after 11 years, with ibrutinib with idelalisib, who seem to control the disease for years, then if we want to compare new drugs in the field, then we have probably to follow up the studies for 5, 6, 7 years before getting to assess if the new drug is better or not. So that's why FDA organized this workshop to discuss the possibility of use MRD in CLL as a surrogate endpoint, a single assessment of MRD 3 months in the bone marrow after completion of the therapy would suffice. Would be sufficient to define the efficacy of a new drug compared to the old ones. We have still to see what's going to happen if the FDI will actually consider positive the evidences that we brought. Probably this will become part of the future FDA guidance for the clinical trials. Having said that, I conclude, and I thank again all the people working with me, and especially all the people all over the world who helped to set up the flow cytometry 4 and 6 color protocol. Thank you so much.